it's abdominal obesity. Because some people with big body mass index are muscular, and so you have to throw that out. So we're looking specifically at waist, hip ratios, and abdominal obesity to reduce in that priority. Other things, family history of atherosclerotic disease did not come out as a significant variable once we included all of the others that were seen there for that. GFR under 60 thought to be, wasn't as high a risk factor as we thought. And diastolic blood pressure, especially for people over 50 years of age, no longer is a risk factor in that group. We are looking at potential risk factors. Some data suggests that an elevated HS-CRP will double your risk of having an event. That is an HS-CRP above 2 or 3 in Ridker's studies for that. ApoB may be also a risk factor, microalbuminuria, cardiorespiratory fitness, and coronary artery calcium score. Elevated coronary artery calcium score will increase your risk 2 to 5-fold in the population. Increased intimomedial thickening of your carotid and abnormal ABI indices, meaning arm blood indices suggesting peripheral vascular disease. We do have those as risk factors. There's not quite enough data yet to include those in the overall pool. But the way to get to zero is just eliminate all of the variables that are in these equations that we have in every ethnic group in 52 countries, and we can get to pretty close to zero, under 10% with that. Those are the phenotype manipulations and identifications. We also now are up to 160 genes that we've identified that are associated with having a myocardial infarction. And these genes are either causal or susceptible or associated with coronary disease and myocardial infarction. Here is each of the genes from 1 to 22 that you have here. We have the location of where they are on each of those genes, so we can identify each of these genes. They may deal with an LDL receptor, may deal with a PCSK9 gene that codes for high. We know where the locations of this bad information is, and we know that 50% of your risk sitting here today is related to the gene pool that you're carrying with you from that. And you would say, well, that's fine to talk about genes, but what can we do about it? Those are our parents, etc. Well, we happen to be at UC Berkeley today, and UC Berkeley, as you know, was the inventor of the CRISPR tool for modifying those genes. So the CRISPR-Cas9 gene pool tool can eliminate these bad genes from your genome, and none of your descendants would in fact have to deal with it. We could eliminate 50% of cardiovascular disease overnight. Am I saying we're going to do that in this program? No. But maybe 10 years from now, we may be talking about ways of further reducing this, especially in very high-risk individuals. So that tool is available today. Whether it's ethical, we'll have to decide at the next conference. Whether it's pursuable, we'll have to decide at the next conference. So come to next year's program, and we'll talk about that for that. How about cost? So we talked about the fact that we have to be cost effective. Why is that? Well, our cost is exactly double what it is in any other Western country for healthcare. We're exactly 17.8% of our GDP is for healthcare costs. The next highest country is about 12%, and every other country is lower percent for healthcare for that. And for that reason, we have to lower our costs. Despite having the highest cost, we run the lowest life survival in this country. So for that cost, we don't get good results. So how do we reduce those costs? Well, we can see administrative costs are 4 times higher here. Pharmaceuticals, we pay twice as much as anyone else. Physicians, twice as much. And nurses, 1.5%. So to lower those costs, we're going to have to do it without these facilities. So I like the idea of trying to use something that avoids physicians and avoids expensive healthcare individuals that was talked about earlier today. What have we done in California? Well, you can see we started in a program for elective PCIs. We started with a program, introduced legislation, got the concept, passed the legislation, gathered evidence, looked at outcomes, looked at guidelines, performance measures, came around again, introduced another bill, SB 357, went around the circle again, and looking at outcomes, changed our mode, and then lastly introduced another bill, 906, currently the law in California for that, to reduce outcomes in patients who were off-site PCI. And last year, I can tell you that what did we get? Last year, for the elective PCI program in the state of California, for all of those hospitals participating, did we get the zero? We got 0 strokes, we got 0 myocardial infarctions, and we got 0 mortality. We got to 0 with intensive program that went around this loop looking at all of this for thousands of patients in the hospitals with off-site PCI in California for that. I remind you that going around this circle is getting to 0. The circle is in the shape of a 0. But interesting, what we identified for those, we were much better than the other hospitals not in the program. We identified off-site or on-site outliers. We identified 25 hospitals in California that had double or triple the mortality or the event rate from the same procedure in the state of California. We're now working on those outliers. We've identified them. We've contacted them. We're working with their CQI programs. We know how to lower the event rate in PCI. We're working with those hospitals that are above average statistical outliers that are lowering those. Those are hospitals with existing on-site cardiac surgery for that. So what have we done specifically in Sacramento? Well, we're working with Right Care to try to get, in fact, this information from just not the healthcare leaders, but down to the providers and down to actually the patients at that time. We've done outreach programs. I now have 1,500 firefighters enrolled in a program where we monitor their health. We get blood tests done, and we're getting calcium scoring on those so that we can lower the risk in firefighters, which, as I said, is a 2 to 10-fold increased risk of having an event for that. We're trying to move out into other high-risk groups, but we want to get to the patient and to the community. So we're contacting barbershops, religious groups, clubs, regions, and neighborhood programs to try to move to the location. We have to get to where the patients are for that. Other things, as I said, we introduced legislation, very effective, very hard to do, but when you introduce legislation for, let's say, our school obesity program, when we started out, we had a commission. We introduced 2 bills, Senate Bill 12 and 965, school obesity and fitness. When we started out, the average school lunch in California was 55% fat calories when we started out. We now got that down to less than 25%. When we started out, the average exercise time in school in California was 0 minutes was required in California schools. Today, average school in California requires 30 to 40 minutes of exercise today. And today, 6.3 million kids in California had to exercise 30 to 40 minutes because of this bill that we passed. And we've been able to show, and we published, that there was an improved fitness in California and a reduced increase in obesity in the school kids of California compared to other states that were near us, same ethnic populations for that. In addition, I showed that we introduced, I wrote SB 891, 357, and 906, and those were improving hospital access, PCI, and that's where we got the 0 strokes, 0 MIs, and 0 deaths in that code. And we're working with evidence code 1157 for the hospital outliers in the other hospitals in California, and I have another 130 hospitals that we monitor for that. We're able to negotiate lower costs because that's also getting to 0. And what we started out in UC Davis was a cost for a calcium scan of about $700 to $800. Trying to get that down was critical because it is a cash pay. We were able to negotiate that down to $150 for that. And with that, the firefighters are paying, the firefighters department is paying for the firefighters for that $150 to do it. We're negotiating right now with Kaiser on a bundle for the blood tests as well at a lower price for that. So what have we seen? We were able to go around the circle, get the 0, but the future is bright, as we can see. We talked about a lot of things today, digital health monitoring. We'll be able to monitor better than A1C. We want to go to continuous glucose monitors with a chip in these individuals. We've looked at big data, where we've looked at that big data, we've gotten the ability to reduce outcomes with that. And we now know with PCI how we can reduce outcomes in specific patients. But we realize every patient in the lab requires a different set of medications that they respond to lower it. So we know that precision health is important. We've got to use big data so that we can now apply this information in digital health to the precise difference of precision health for individual. Every one of us is going to require a slightly different algorithm and a slightly different treatment for that. But as we look to the future here, it's a bright circle that we see here, and that bright circle is in the same shape of getting to 0. Thank you very much.
Dr. Tony Kuo from Los Angeles Public Health is one of our great Southern California leaders, and he's the physician director for chronic disease for the 10 million person county of LA. Thank you, Tony Kuo, for being with us.
Thank you, Hattie. I don't have any slides, so that's the good news, but I think I may be at 0 as far as the time goes. But I just want to offer sort of the perspective from LA. I know when Hattie had asked me to join Right Care Initiative, I had originally thought, well, she must have the wrong guy. She's looking for a cardiologist, not a family physician that works in public health department. But upon further reflection, I did some homework, and as you know, LA, if you think about all the great progress we've heard today, LA in some ways is along that path, but there are other parts of LA that pretty much is the outlier where all the challenges still remain. So to give you an example, we know that Healthy People 2020 target for mortality for coronary artery disease is about 103 per 100,000. But in LA County, we're still at 117, so there's much more to be done. Another example, the other day, I think CDC had released their smoking prevalence data, and I think California is down to 8%, so I think that's worth applauding. And likewise in LA, if you look at from 2012 to 2016, we had actually decreased from 13 to 11.5%. The only problem is when we actually break it down by some of those vulnerable subgroups. You look at African American, it actually had increased almost 21-fold. It's it's like 15% in prevalence for some of these groups, all the way up to 22.5%. So we really, in some way, haven't made the progress that we ought to be making. So how does this all kind of coalesce around Right Care Initiative? We kind of view this as an excellent opportunity to kind of build out a learning system for LA County so that the haves and have-nots can actually meet together and actually come up with solutions and actually share their best practices. And as you know, Kaiser Permanente continue to do great work in Southern California, but we do have our safety net health system, which could learn a lot, and I think that's where at least in LA, where this initiative is really striving to. And it really would open up a lot of opportunities in terms of being able to scale and spread things like the National Diabetes Prevention Program, the pharmacist interventions we talked about, even screenings for some of the vulnerable populations. And the nice thing about going last, of course, is it looks like the equation has been done. And I think where we play a role, especially a health department, I think in many of your communities, you might want to reach out to them. We are potentially solutions to many of the elements you have talked about. We are working on things like food insecurity. We are working on things on psychostressors, screening for depression, helping health systems. We are trying to improve physical activity programming, but through a different sort of mechanism, using policy, system level, more global, larger strategy approaches. And so with that, I'll give it back to you. Thank you.
I think, Hattie, we are out of time on this panel, so I think we had a very good discussion, very good from all the members. Do you have anything in the close?
Excellent progress on getting that equation started. I'd really just like to welcome you all to send me your ideas offline. If you're on a walk on the beach and it occurs to you, aha, we should be doing required CME on the ALL bundle that Jim Tuttle created at Kaiser with Greg Fonero at UCLA. There are some really powerful levers that we haven't pulled yet, and I think one of them is legislation, and we're very grateful that Dr. Balmer has quite a success record there and has a lot of aggressive ideas on how we're going to reduce preventable cardiovascular disease in the state. So with that, I think we should move to the next panel, the patient aggravation panel. Yeah, sure. Yes, Steve.
So I think we can move and other people can come in. So go ahead.
Steve Sidney, Kaiser Permanente, cardiovascular epidemiologist. And one thing I don't think I've heard too much about, and there's a couple of facts, is one is that if you get to the age of 50 without any risk factors, without having them treated or existent, then you have an extremely low risk of developing cardiovascular disease the rest of your life. The second thing is that if you have any of these risk factors like blood pressure, hyperlipidemia for any period of time, and you treat it back to normal, your risk does not go back to the same as a person who has a normal blood pressure or normal cholesterol. We've shown that in the Cardia study, which I am part of, and one of the ones that Dr. Bonner mentioned. So the real key here is in childhood. And I don't know if there's any pediatricians here, but the pediatricians are really voices that should be heard here, because it's preventing kids from getting involved in having risk factors in the first place, being obese, smoking, and God knows what these e-cigarettes are doing now when we've heard about them. So I just wanted to make that point. Just treating people and getting their risk factors down to normal is great, and it's great to see we're doing better, and it does make a difference. But it's not going to get us down to zero. We've got to start at the beginning.
So we're headed for the home stretch. Thank you for that. And the whole, just building on that first 5 movement in California and nationally, what happens in utero and those first few months and first years of life feed into everything we're talking about today, actually. And that's something we might want to emphasize more in future summits as well. So we started this morning with the patient and family, and we're going to end this next 45 minutes with the patient and family engagement. We started with Chuck's very moving story and experience, and we're going to end with some of the things that are going on to better engage patients and families. And we're going to start off with Victoria Dupai, and she's the founder and executive director, No More Broken Hearts. And she'll be followed by Lavana Blair-Lewis, who's teaching professor at USC School of Pharmacy and she's also the co-chair of the Los Angeles University of Best Practices. Liz Helms, as many of you know, is president and CEO of the Chronic Care Coalition here in California, and will wind up sharing a few results from a study of the Patient-Centered Outcomes Research Institute that Hector Rodriguez and I have had an opportunity to do. So let's begin with Victoria.
Hi, everyone. First of all, I just want to say I'm going to kind of piggyback on what Chuck said when he started his quick story is I'm not a doctor, but being here today, wow. So Hattie, kudos to you, kudos to everybody who's presented, because it's just been really a lot of great information, a lot of great conversation. I will tell you, though, that I've always considered myself to be a woman on a mission, but unfortunately in 2013 I became a widow on a mission. And I'm just going to share with you my little story. And Hattie has asked me to, from a patient standpoint and a widow standpoint, a call to action to all of you out there. So this is my husband, Dean, of 20 years. That was our last date night, and a week before he died of a heart attack. He was 46 years old. He had just been to his doctor for his annual exam, which he passed with flying colors. And we now know he was playing ice hockey and had heart disease that went totally undetected. As I came to terms with what my world had just fallen out, I called his doctor a couple days later and asked him if he had missed anything in his annual exam, because he didn't have any risk factors. And again, he was 46 years old. He was playing ice hockey. This picture in the middle of him in the green shirt with our daughter, that was 8 hours before he died. He had done the Muddy Buddy race that morning with our daughter. And his doctor said to me, you know, Victoria, I'm so sorry for your loss, but it's just not something we test for. It's not like getting a mammogram or a colonoscopy. Unfortunately, my story is not that unique. I bet you, well, let me ask you guys, how many of you, well, I shouldn't say that because you're all you all know somebody that's had a heart attack. Okay, so forget that question. But unfortunately, my story is not that unique. And as I dove into learning more about heart disease, because I really thought that we were doing everything that we were told to do, I was really surprised at what I did learn. Today, it's been amazing to see how much progress is made in the management of the risk factors. But like anything else, I like to use the analogy of pipe and water. So if you want to see if there's corrosion inside of the pipe and you're testing the water, I don't think you're really going to get a good idea if there's corrosion inside of the pipe. And as we know with the stats of heart attack, it happens every minute of every day. And as Alan said, where's Dr. Fremont? As Dr. Fremont said, it's not just about the cost, to the managed healthcare, but it's all of the lives that change. Every single one of these pictures here, you got to multiply probably about 10 of people whose hearts are broken. Family members, parents, co-workers, friends. We can manage the disease if we know that the disease is there. One of the things, when Dean's doctor said to me, Victoria, it's not like getting a colonoscopy or a mammogram. We know, and I'm not a physician, but we know preventative screenings save lives, without a doubt. We perform over 37 million mammograms a year, with an average amount of deaths in the 40,000s. There's over, 14 million colonoscopies per year, with an average death of about 50,000. We have over 960,000 deaths per year from cardiovascular disease, and you can't even measure getting a heart scan. Heart scans save lives. Coronary artery calcium scans save lives. And unfortunately, it's not talked about by our doctors, and it's not paid for by our providers. And yet heart attacks and cardiovascular disease is still the #1 killer. Why is that? Why is that? So, I know I was only supposed to take 5 minutes, so I'm going to move to my own personal call of action to all of you guys, especially the providers. Please consider covering this. It's not an expensive test. It cost way more. My husband was in the hospital for 5 hours. He did not survive, and his hospital bill was hundreds of thousands of dollars, which fortunately I had great health care, and I paid $200. We know what it costs you guys, so please consider covering it. If we're covering, mammograms, if we're covering colonoscopies, and we're covering CT scans for liver disease and kidney disease and lung cancer, why would we not do it for the heart? Because frankly, if your heart stops, it doesn't really matter what other disease you got going on. Second call of action for all the physicians out there, please talk to your patients and start even with the ones that are at intermediate risk. Your patients with diabetes, your patients with hypertension, your patients with some family history, okay? Start with even those. We know that those are significant risk factors. Get a coronary artery calcium score, look inside the heart, see if there's plaque already building up so that you can really manage it with your patient. I will tell you, every week I'm getting new stories in our community from other people that have the same story. And I will also tell you that people in my community that have gotten a heart scan because of what No More Broken Hearts is doing, and they have been recommended by their patient to take medication, and they don't want to because of their ego a lot of times, but they don't want to. When they see that they have heart disease, it changes them. They want to do everything that you are partnering with them to do because they see the disease itself. So please consider our call to action. Thank you so much for letting me be here and share my story. Oh, and by the way, the books that are out there, Take It to Heart and Dead Execs Don't Earn Bonuses, please take them as my gift. They're great books.
Has been one of our great right care volunteers since the beginning of time. Since before we had our first summit, she was there at my side along with Steve Shortell getting this going, and she helps lead our Los Angeles work and a lot of national work on health disparities. Thank you, LaVonna, for making the trip up.
Thank you, Hattie, for the invitation. So I'm LaVonna Lewis, you've already heard that, and I'm here for a call of action. I work at a policy school, and so you're going to get kind of a policy perspective. But I want you to understand that I am also the first black woman that's been at this podium. And so my call to action is around the population that's been discussed as kind of the disadvantaged group. I'm one of those demographics. I represent that demographic. And so this call of action, as a policy school, you know that words have power, pictures have power. And so there's been a lot of data that's been presented today. And I think that there are three possible responses, at least three possible responses to what you've heard today. One response is, so what? And we may be happy with the status quo and decide we want to do nothing. Another possible response is, now what? I can wait for the next shoe to drop and see what's going to happen next. But what I would prefer the response to be is, this is what I will do. This idea that I can't do everything, but there is something that I can do that can contribute to reducing the premature death in the black community. And so let me say that Black Lives Matter too. It does not matter if the premature death is the result of gang violence or police violence or premature death because of a heart attack. Black Lives Matter. I want you to understand that this issue in terms of understanding that there are partnerships that are available in the community. I heard some preliminary conversations are alluding to partnerships that have been spoken about, but there are some very robust partnerships that are going on right now. And I want us to understand that there's also where I'm born, where I grow up, where I work, where I live, if those are the places where I'm spending my time, where I'm making my health decisions, how much do we know about the clinical, the patients that you see and those environments? To really address some of these issues, we have to get into the communities and maybe deputize people in the community, maybe trust people in the community. I was very happy to hear someone mention mental health. Life always wins. And if I'm struggling to make ends